I'm talking about the evaluation of Sjögren syndrome. This is the outline we are going to follow. First, I will talk about the evaluation of dry syndrome using different items, and then the assessment of disease activity. I also wanted to include the evaluation of treatment response here, but I won't be covering that. My colleague will talk about the treatment later. Let's begin with the first part, the evaluation of dry syndrome. We have salilometry, which allows us to measure salivary flow. And we have basal or unstimulated flow, which must be performed without exception. In the morning, between 9 and 11 a.m., it lasts about 15 minutes, so it's a short test, but it must be done under specific conditions beforehand. There must be no stimuli, that is no chewing gum, no smoking, and the patient must be fasting, both from food and water, okay? And this technique is easy to perform. The patient spontaneously deposits saliva into a graduated container, and it is considered normal when it exceeds 1.5 milliliters in 15 minutes. And then we have the stimulated basal flow. Here we use stimulants such as lemon juice, paraffin gum, which is chewed for 30 seconds, and medications, especially pilocarpine. Here I've provided an example using pilocarpine. First, we would collect the basal flow, as I explained earlier. Then we would administer the pilocarpine, wait for an hour, and collect the saliva again, now stimulated. A result is considered normal if it is equal to or greater than 1.5 milliliters in 15 minutes. This test is interesting because it allows us to assess glandular reserve and also gives us insight or the idea of potentially using medication in these patients. That said, remember that pilocarpine cannot be given to patients with poorly controlled asthma or heart conditions, okay? So they would not be able to undergo this test with this medication. This is the container we use in the clinic to measure salivary flow, okay? And now we move on to tear hyposecretion. We have both quantitative and qualitative tests. For the quantitative ones, we first examine the ocular surface, especially the tear meniscus on the inner side. And the gold standard test is the Schirmer test, where we use these strips you see here in both eyes, and it's considered pathological. If it's less than 5 millimeters in 5 minutes, regarding the qualitative tests, we use dyes, which we will later rinse with saline solution because they are irritating. But this allows us to stain the corneal epithelium, and it must be evaluated using a slit lamp. Therefore, we need an ophthalmologist, as we have no idea how to do that. And the Fitchbell score is used, or however it's pronounced, and it is assessed. The 3 zones of the eye are evaluated, and depending on the concentration of the dye, a score is assigned. It is considered pathological if the score is greater than or equal to 4 in each eye. We have another scoring system, which is the OSS score, which also evaluates these 3 zones. The maximum score is 12. It is generally considered positive when it is greater than or equal to 3. But according to the ACR-Euler criteria, it is considered positive if it is greater than or equal to 5. And then we move on to glandular ultrasound. Here it will allow us to assess mainly the parotid and submandibular glands. We look for structural alterations, and it is considered normal if it is homogeneous, well-defined, shows hyperechogenicity compared to surrounding tissues, and is especially similar to that of the thyroid. The good thing about this test is that it is very specific, over 90%. And it has been associated, as we will see later, with patients who are anti-Rho positive and have an inflammatory infiltrate in the biopsy. This is how it is assessed using the probe and the normal image of the parotid gland. And this would be with the submandibular gland. This has been graded according to the level of involvement into 3 grades. Well, 0, 1, 2, 3. And then a fibrotic grade 3 is also included. And this is the classification we all know, OMERACT. Grade 0 would be normal parenchyma. Grade 1 shows minimal changes. At this stage, there are still no anechoic or hypoechoic areas. And then in grade 2, moderate changes appear, and there are indeed affected areas. And grade 3 would be diffuse or severe changes, where almost the entire gland is affected by these anechoic and hypoechoic areas. I've brought some articles to take a closer look at the usefulness of ultrasound in current clinical practice. This is a 2024 article, quite recent, which evaluates the involvement through ultrasound and relates it to findings on MRI and abnormalities in the salivary test. This is what we've seen regarding the involvement of the glands on ultrasound. Here we have the involvement seen on MRI, which I won't go into further, but there are also grades 0, 1, 2, and 3 of involvement. And as conclusions from this article, it shows that ultrasound graded by OMERACT has a moderate to strong concordance with the abnormalities observed on MRI and with the presence of hyposalivation, especially in the parotid gland, more so than in the submandibular gland. This 2023 article also evaluates the use of ultrasound for making a differential diagnosis. And it finds that, indeed, it has a high capability for making a differential diagnosis, especially with diseases that alter the structure of the gland, such as sarcoidosis, amyloidosis, HIV infection, and chronic infection by the T virus. This 2018 article, as well a bit older, already showed this here. The usefulness of ultrasound, especially because it correlates with what is observed in the biopsy, with the clinical presentation, and with serology, particularly with anti-Rho antibodies. And this article, which is also recent, I find very interesting because it evaluates not only the parotid and submandibular glands, but also the lacrimal gland, okay? This is what it would look like, okay? It's very small, it's hard to find. And the downside is that we have limited experience with this, okay? There isn't a standardized classification, for example, but a descriptive analysis. What do we see? For example, is the parenchyma normal? If not, what about gland size? Is it normal or enlarged? Are there hyperechoic spots? What is gland like? Is it fibrotic or not? Is there fat deposition? That's all, but I find it very, very interesting because also, as a conclusion, they see that changes in this tear, when it has a score higher than 2, are related to patients with Sjögren syndrome, okay? Especially due to the alteration at the lacrimal level as well. And I wanted to wrap up the topic of articles with a study we conducted in our department. It also evaluates the use of ultrasound in these patients in clinical practice. To summarize everything and move on to the conclusions. That is, indeed, ultrasound improves the performance of the classification criteria when added, and it is also superior to salilometry. Now I'll move on to salivary scintigraphy. It's a test that is currently used infrequently because we have other tests that are more helpful and easier to perform. However, this test does help us assess glandular dynamics and reserve. It uses technetium-99 and is more sensitive than specific. It only evaluates the parotid and submandibular glands, as these are the only glands capable of concentrating this technetium. And yes, there are hotspots visible in the scan, which are associated with the salivary glands, the thyroid, the oral mucosa, and the nasal mucosa. When is this test indicated? Well, it's used in the evaluation of a patient with xerostomia. Let's remember that this test was included in the 2002 criteria, but not in the 2016 ones, okay? If we have doubts with the other test, we can request this one, okay? But as I said, it's not the usual approach. It's also used when there are developmental anomalies of the glands, in obstructive processes, when there are fistulas or traumatic injuries, or after glandular surgery, if we want to make sure that the entire tumor was removed during the procedure. And what about the phases of this test? Well, there are 3 phases. The first is the vascular flow phase. It shows bilateral and symmetrical flow in all the glands. The second phase is the concentration phase, where there is increased activity in the parotid and submandibular glands. And the last is the secretory phase. Everything is expelled through the saliva. And there are also degrees of involvement. 4 grades. We'll go through each one, and the image on the right is usually related to the grade I'm going to talk about. Grade 1 is normal. The final activity in the mouth is greater than in the gland because everything has been expelled. In grade 2, there is mild involvement, where the activity in the mouth is lower than normal or is equal to that of the salivary glands. Grade 3 is a moderate involvement, where no activity is observed in the mouth at the end of the test. And grade 4 is already a severe involvement, where there is a complete absence of glandular activity throughout the entire test, not just at the end. And I mentioned that scintigraphy is being used less and less because a correlation has been found with salivary flow. It has been observed that a normal basal flow is associated with grade 1 or 2 on scintigraphy, and an altered stimulated flow has been associated with grade 3. So if we have the salivary flow test, scintigraphy is not necessary. Now we move on to the salivary gland biopsy. When is it indicated? When we want to make a suspected diagnosis of Sjögren syndrome. It would be considered the last step in the process, even though it's easy to perform. Now we'll see how it's done. And also when we have doubts about the diagnosis and want to perform a differential diagnosis with other conditions. We usually perform a biopsy of the labial mucosa, which involves taking the inner part of the lower lip, making a small incision, and it's important to collect a sample that contains at least 4 lobules of the sample. These are some recommendations on how to handle this test that we're going to obtain. And above all, emphasize here that the sample must be preserved in 10% neutral buffered formalin. And it must be sent to the pathology department within 24 hours, otherwise it loses quality. Remember that the biopsy is included in the ACR-EULAR criteria, and it carries a fairly high score of 3 points. What is typically observed is focal lymphocytic sialadenitis, with a focus score greater than or equal to 1. The biopsy has been evaluated in different ways. We only focus on the focus score. How is the focus score calculated? Well, it's the number of foci in the sample divided by the area of the sample in square millimeters, and then multiplied by 4. And this is what is typically seen, focal lymphocytic sialadenitis, which we will see in an image on the next slide. But we also see that in the Sjögren syndrome in advanced stages can present with non-specific chronic sialadenitis, meaning it can also show other changes that might make us question the diagnosis a bit. And this is what is typically seen, focal lymphocytic sialadenitis, where you can see a cluster of more than 50 lymphocytes indicated by the little arrow. And this is typically what a biopsy report would look like. From the minor salivary gland, where the report describes the macroscopic findings, the microscopic findings, here they mention the lobules, the typical characteristics, the focus score, and the final diagnosis, which in this case was indeed the typical focal lymphocytic sialadenitis, and it had a focus score greater than 1. And now I'll move on to the second part of the presentation, where we're going to talk about activity assessment. The ESSDAI is the gold standard. These are the initials for the Euler-Sjögren syndrome disease activity index. And in addition to assessing disease activity, this index also allows us to evaluate treatment efficacy and response. It is sensitive to change and evaluates 12 domains, 10 clinical or organ-related, and 2 biological or laboratory-based. And for the calculation, both the activity level of each domain and its assigned weight must be taken into account. Now, we'll look at some examples because it's not complicated, but it can be a bit confusing, although there are also online calculators. And these are the domains it takes into account, whether there is constitutional involvement, lymphadenopathy, glandular, articular, renal, or muscular involvement. And on the biological level, hematological abnormalities in lab tests or biological markers, which here include immunoglobulins and complement. And I'm going to go through this example to show you a little bit how it's calculated, although honestly, with the online calculators, it's amazing. So for example, we look at the constitutional syndrome, which has a weight of 3, and the activity level will be scored as 0, 1, or 2, depending on the symptoms the patient presents. For example, if there are no symptoms, it would be a 0. If they have a fever between 37.5 and 38.5 degrees, night sweats, or weight loss between 5 to 10%, that would be a low level, which is a 1. But since it has a weight of 3, you have to multiply it by 3. So it would be 3, okay? That's the final score. You always have to remember to rule out other causes like infections or intentional weight loss. So in that case, it wouldn't count. And here's another example. For instance, glandular involvement. This one has a weight of 2, so you would multiply by 2. You always take the highest score. I've included it here in the presentation. The calculation for each one, okay? But I'm not going to go into each one because it would be a drag and a mess. All right, and indeed, we have this graded, okay? Depending on whether the activity is low, moderate, or high. Low would be below 5, moderate between 5 and 13, and high is 14 or above, okay? But in addition, improvement has also been defined clinically relevant, and it has been defined as such with an improvement of 3 points or more. And then we also have the clinical ESSDAI, which is also frequently seen in studies, often even more than the ESSDAI. The clinical ESSDAI is the same as the ESSDAI we explained, but it removes the biological item, meaning it does not take into account immunoglobulins or complement, although it does consider part of the lab work. And it scores differently in terms of weighting, but then it's graded the same way, meaning low, moderate, and high, it's the same. The cutoff points are identical. And then we have another index, which is the SPRI, which allows us to assess the severity of disabling symptoms, evaluating pain, dryness, and fatigue. These are the questions asked in this index, where we see that 0 would mean no symptoms and 10 would be the maximum. And then we have this score, which measures chronic damage, where the score ranges from 1 to 5. The maximum is 5. And it takes into account oral involvement, ocular involvement, neurological involvement, pleuropulmonary involvement, renal involvement, and lymphoproliferative involvement, which scores the highest, with 5 points. And now I'll finish with my conclusions and give a brief summary of everything I've discussed. In the first part of the evaluation of dry syndrome, remember that basal flow is considered normal when it is greater than or equal to 1.5 ml in 15 minutes. And the stimulated flow, for which pilocarpine is commonly used, is also considered normal if it is greater than 1.5 milliliters in 15 minutes. The Schirmer test, which is used to assess ocular involvement, is considered pathological when it measures less than 5 milliliters in 5 minutes. And glandular scintigraphy, which is becoming increasingly important, and with all the articles we've reviewed, it will be used more and more in clinical practice. It is considered pathological when involvement assessed by OMERACT is greater than or equal to grade 2. Scintigraphy allows us to observe the dynamics of glandular reserve and the labial biopsy. It is included in the 2016 ACR-Euler criteria. And the typical pattern is focal lymphocytic sialadenitis, and it must have a focus score greater than or equal to 1. In the second part, the assessment of disease activity, the most important and most practical tool we can use in clinical practice is the ESDI. But remember SSDDI, ES-SPRI for assess chronic damage, see if fatigue and pain remain.